thromboembolism ranges anywhere between 8% and 69% in this series. This one is a very small series, only 26 cases from France. Can you see the image right, or do you want me to zoom into that? Can you see that okay?
Yeah, that's perfect.
Yeah, so you have probably seen these papers before. What is interesting though, this is the proportion of patients that actually got a clot. And when you look at the cumulative incidence of these clots, is probably higher. In this paper, it was just updated about 3 days ago, and the cumulative incidence at 2 weeks is 49% according to this series. Now, the question though is whether this is actually a real finding in these patients or not. It probably is, but I don't think it's in all newcomers, and that is the main problem. All of these patients actually are patients that were admitted to the ICU. In some of these studies actually had patients, for instance, this one reported, this is another Dutch study, it reported 34% cumulative incidence at 14 days. But if you look at the numbers of patients, this was particularly high for patients admitted to the ICU, but not for those patients admitted to the ward, in which they only found about 3% of clots in those patients. So, and the other thing that has happened with all of this literature is that it's kind of biased and it's not very unclear, because in many centers, they use specific protocols regarding standard surveillance for patients admitted to the ICU. Like this one, the one that reported 69% of patients with clots, they use systematic ultrasound screening in all patients, which is not standard practice and certainly not in Canada. And we do know that in studies, like for instance, from many years ago, when you looked at studies looking at primary prophylaxis in patients with orthopedic surgery, if you do a systematic ultrasound screening, you're going to find much higher numbers of clots, which does not necessarily mean that you are going to be seeing many clinically relevant events. In spite of that, I mean, I think that it is significant enough for patients admitted to the ICU to be at least followed very closely. And probably, I mean, in patients who do have significant respiratory problems, which most of them do, the imaging protocols for chest probably should include a CTPE protocol, not only a standard CT scan protocol. Now, whether this is different than other situations, we don't know. And the reason for that is that there's also been studies in the past looking at very sick patients admitted to the ICU with, for instance, with severe sepsis, with very high scores. In those patients, the reported frequency of VTE is about 40%. So whether this is actually something that is exclusively associated with COVID, probably, but I don't think so. I think that this is probably a reflection that these patients are really, really sick. Now, there's one interesting paper that was published it's this French study here, the Helms et al. French study. This is an interesting one because what they did is they did propensity score match analysis. So they matched a number of patients with COVID-19 to other patients with ARDS that had no COVID. It was a cohort of historical controls. And they matched them according to disease severity and all of the functional and severity scores that are used in the ICU, Apache, and all those things. And they actually did find a higher frequency of thrombosis in the COVID cohort, which was about probably double the one that was reported in the controls. But it's the only one that has done that. And it does have some caveats because it may be that there are differences in actually the number of images that these patients get. So it's not completely clear, but it's certainly something that is worth noticing. Now, why is it that patients with COVID-19 have significant hypercoagulability? We don't know, and this is the main issue right now. What has been found so far is that the COVID-19 patients with COVID-19, they do develop significant microcapillary thrombosis in the vessels, and then they, at the end of the as the process continues to worsen, the disease continues to worsen, they start developing intraalveolar fibrin deposits, and some people say that that's probably why these patients develop clinically asymptomatic severe hypoxemia prior to these patients crashing. Because it's not until a later phase when the alveoli are occupied. Why is it that COVID does that? It's not known, but it's known that at least in some patients, there is a significant dysregulation of the endothelial cells. And this dysregulation of the endothelial cells might actually predispose patients to more microcapillary events. But why is it that some patients develop this and others do not? Nobody knows. And the reality is that the frequency of thrombotic events, I think, is, in a sense, is probably overestimated, because you are using here in all of these studies, the denominators are only patients who were admitted to the ICU. So if you look at the denominators as patients who do have positive COVID, in general, the actual number of thromboses are going to be very low, much lower than what has been reported. And again, bear in mind that these numbers are basically for ICU patients. So these are the most seriously sick patients. What is actually noteworthy is that these findings have been reported also in China. And there is at least one study that has been published here, plus another one that I actually reviewed not too long ago, that report probably about the same thing. The other thing that is kind of interesting is that in many of these cases and many of these series, the number of pulmonary emboli that are diagnosed is significantly high, which is kind of weird, because in terms of VTEs, you can usually assume that when you look at a cohort of patients, the frequency of PEs is probably about 1/3 to 1/2 of that of VTEs. But in these patients, it does not seem to be the case, at least not in these studies. So the number of PEs seem to be much higher than what we are usually seeing. Now the question is, what do we do with these findings, and whether we should be looking at putting patients on anticoagulation from the start and from the very beginning, because that's what has been going all over the news now. It's the clots in COVID patients. The reality is there's no information at all. So if you look at the guidelines, there's guidelines from the American Society of Hematology that are available. It's not actually guidelines. It's more like a general sensical recommendation, and it's basically keep all patients on prophylactic anticoagulants, but don't do it otherwise, because we don't know whether that's actually right or not. But if you look at, for instance, the Italian guidelines, they tell you that you should probably increase the anticoagulation doses. The Spanish guidelines say the same thing. The Swiss guidelines are kind of in between. And then there's several centers in the States are doing different things. The same happens in South America. And at the end of the day, what's happening is that we're putting patients under treatment regimens or prophylactic regimens that are not well proven, and which actually may end up causing more problems than not. We know for other conditions that using higher doses of anticoagulation may actually decrease the frequency of thrombosis in some patients, but it always does so at the expense of an increase in the risk of bleeding. And although bleeding diathesis does not seem to be the most common presentation of COVID-19, it is certainly something that can occur in that way because of a number of other problems. But the issue here is that if we're going to be increasing anticoagulant doses, let's say doubling the prophylactic doses or using 50% therapeutic doses, it should be within the realm of properly conducted study, because we just don't know whether that is the right thing to do. So that is the reason why we just issued and drafted some guidelines for our center, which in general, what they say is do what we are already doing for most patients. And we are happy to discuss whether some other patients, especially those who need to the ICU, may actually be candidates for other interventions. But again, I mean, at this point, there's going to be a couple of trials that are already being launched or will be launched very soon. One of them is the ATTACK trial. And these are not the only ones. There's at least 5 or 6 going on in the States and Europe, and these 2 in Canada, that are looking at different anticoagulation regimes. What is a real thing is that putting patients on full anticoagulant protocols without an indication for that, it should be a no-no. So in general, I think that that is the main thing. The other interesting finding that has been all over the news as well is the relevance of D-dimer testing in these patients. And again, the answer to that thing, to that question, is whether we know that these patients' D-dimer levels are pretty high. And if you remember, the D-dimer is nothing else but a marker of the activation of the coagulation system. It basically means that patients are generating too much fibrin, and then the fibrin is being degraded very quickly. So in COVID patients, the D-dimer levels have been reported to be elevated, but again, not for everyone, and it's usually it's studied in most patients that actually are very sick. It doesn't completely, we don't really know whether in all of the patients these have a real prognostic value. We do know from some studies, especially one Chinese study published in March, I think, that did report that D-dimer levels are prognostic of poor outcomes, and it may very well be the case. But if you look at these studies, when you look at the D-dimer levels parallel other markers. In that particular study, D-dimer levels were basically mirroring elevations and the course of the values of interleukin-6, C-reactive protein, ferritin, and other markers of inflammation. So whether the D-dimers are probably just a companion of the severe inflammatory response, which at some point in due time, it really ends up causing microthrombosis. Whether the use of D-dimers, whether D-dimers levels should be used to guide prophylaxis doses, I really can't answer that. if you look at the literature on this, it has been suggested both ways that probably might help, and it has been also suggested that it doesn't really need to be taken into account. The one problem with the D-dimer studies is that D-dimers and the D-dimer reagents are not equivalent, are not interchangeable. And you really can't extrapolate the results of one reagent with another one. That's always been a criticism of all the pathways that use D-dimers in them. But in general, I mean, at these levels, probably it's not probably that important. The other thing is that when you look at, for instance, all of the protocols and algorithms that have used or have suggested to use D-dimers, they're all over the place. Some of them will give you a hard number. Okay, if we have a D-dimer that's over 3,000 DDUs or whatever, then we should increase the anticoagulation, or we have a patient. And then there's other centers tell you, well, it's 2 times the upper limit of normal or 3 times the upper limit of normal. So we don't know what is the actual answer to that. If you want my personal opinion, I think that these patients, all of these markers obviously indicate poorer prognosis, but they indicate a poor prognosis from the very beginning. In general, I think that what is probably most important of all is monitoring these markers from the very beginning of the disease, when the patients are admitted to the hospital, if they are admitted to the ward, for instance, and following active surveillance, either by using standardized scores, such as the ones that I have been discussing with Claudio, Martin, and some others, like the ISTH-DIC score, which is a standardized and validated score that includes the dimer levels in it. Some of these things that are standardized, and then you can actually use them to see what's the clinical course of the disease. So at some point, you can determine whether these patients are actually going to be doing worse or not, and whether we should be intervening sooner. And at the end of the day, all of this literature is suggesting that anticoagulating patients is what needs to be done. And the procoagulant or hypercoagulable response in these patients is not the cause of the problems, it's the consequence of the problems. It will probably worsen the condition of the patient, but it's not for the most part what's actually causing it. When the patient has had a massive pulmonary embolism in a very damaged lung for whatever reason, that's always a problem. But it doesn't matter if it's COVID-19 or COPD. If the patient has a large pulmonary embolism, it's going to have an impact. And if you have a poor lung reserve, it's going to be even worse. So, that is not the main issue. The main issue here is whether we should be actually doing something more in terms of curtailing the inflammatory response, which is what a lot of people, and that's why you saw all of these trials looking at monoclonal antibodies against interleukin-1, and there's others, like, I don't know if you know that, but the standard protocol, or at least the standard protocol in China, at the very beginning included nebulized interferon. And yeah, all of these interventions are tailored or targeting inflammation, and I think that the role of anticoagulation, or if we believe that anticoagulation alone is going to save these patients, I think we're completely wrong. And so the question is, who should we be putting on higher doses of prophylaxis? I mean, I can't tell you that. What has been suggested by many societies, and that's what should be happening here in London, is that the use of those weight-adjusted prophylactic doses is what is needed, and that is the way it is set up in Cerner, or it should be set up in Cerner. And that's something we have been using for a long time. It is not uncommon to find patients, very heavy patients that are receiving anticoagulant doses that are probably lower than what they would require. But that has been accounted for. Whether we should be doubling the doses in these patients, the answer is still in the air. I don't think we can really support that with very, very hard evidence. The other thing that I wanted to tell you a little bit about is the other problem with this population of patients is that specifically for pulmonary emboli, it is not that easy to make the diagnosis in many cases, because either they are too unstable or because of the isolation protocols, they cannot be transported to a CT scanner. And that really poses a major problem in this population. So if a patient happens to have like that, and the patient has a clinical suspicion of a pulmonary embolism, but you believe that you cannot really move him to the CT scanner, I think that the first thing that has to be done is get bilateral leg ultrasounds. And if you find evidence of a clot in the legs, then there you go, you have your answer. You have to put the patient on anticoagulants. If the patient does not have a DVT, then is when the problems may begin. And one of the things that actually might help in this setting is obtaining bedside echocardiograms to look for either direct imaging of clots, if possible, or indirect findings that might suggest that the patient might have a pulmonary embolism. And I think that if you find a patient like that and your clinical suspicion is high enough, well, then you might probably be justified to actually put the patient on anticoagulants, on full dose anticoagulation, as long as it's properly documented in the chart. And that is accounting for that diagnostic limitation, which is something that we are finding more often, and many centers are finding that very frequently. So following that algorithm, I think that most of the patients should have enough evidence to either start them on anticoagulants, bearing in mind that there are going to be limitations regarding the imaging, and or holding the full anticoagulation otherwise. The other and final thoughts that I had for you was whether we should use mechanical prophylaxis in these patients. Well, I know that's in our guidelines, especially if the patients are bleeding or have any other contraindication for anticoagulants. The use of mechanical prophylaxis in these patients is probably going to be completely useless. I think it will be probably something that you would have to consider anyways, because it's standard of practice, but I don't really know whether this is going to be helpful or not. So the bottom line is that as it stands right now, the recommendations, the one thing that everyone has agreed on is that every patient who is admitted to the hospital with COVID needs to be put on pharmacological prophylaxis, independently of whether they are too sick or not that sick. But everyone should be on it from the very beginning. That's the first point. The second point is pharmacological prophylaxis should be done based on weight-adjusted regimes. And those are usually for patients under 40 kilograms, you would have 2,500 units, and for patients over 100, you would have 7,500 units. There's been some issues and discussion regarding unfractionated heparin in these patients. Unfractionated heparin for prophylaxis should not be used. It should be banned from the face of the earth because it causes more bleeding. It's not more effective. It increases the risk of HIT by about tenfold. And in particular for COVID patients, you're going to have to be exposing the nurses to 3 injections a day when you could actually get away with only 1. So unfractionated heparin should not be an issue. I know that there's some papers looking at the use of heparins in contrast with other anticoagulants because of the known anti-inflammatory effects of heparins. But in every single study where anti-inflammatories, where heparins have been used for their anti-inflammatory properties, the result has been always negative. So I don't think that using unfractionated heparin or heparin just because of their anti-inflammatory properties, I don't think is justified. Do not use unfractionated heparin. The next summary point would be that using specifically D-dimer levels alone to guide whether we should be including anticoagulants or increasing the dose of anticoagulants, it's still in the air. We don't know whether that's the right thing to do or not. And the main problem with this disease is that because nobody knows what to do, we all want to do something. The problem is that we just don't know what. And sometimes we cause more problems than not. The final thing is, I think we're going to have some issues in some patients with diagnosing pulmonary emboli. Probably an algorithm such as the one that I suggested using, leg imaging and echocardiographic imaging, if possible, might actually help to solve some of those patients. But in general, I think that is probably the best way that we can do. I mean, if we had the luck to have a portable CT scanner, that would be fantastic. But yeah, so I mean, I don't know if you have comments or questions. Honestly, I am quite a bit curious about what are we going to find in all of the studies that are going to be conducted. And then, I mean, at some point, we're probably going to have more information to better guide our decisions. But for now, I am not completely sure that we have all the answers. I'm pretty sure that we don't have all the answers, or actually don't have very many answers at all. I don't know if anyone has any questions.
Yeah, that was fantastic. You sold yourself short saying you didn't have much of a talk. That was extremely helpful and informative, so thank you. If people have computers, maybe if they could